to the actual format of this session, and we weren't requested to necessarily prepare anything. So we're quite happy. So Dr. Hassani is going to start by giving a short talk on angle closure glaucoma and management. And then what we can do is do a question and answer session. So we're quite happy to take any questions and queries on angle closure glaucoma, and hopefully that will be of use to the audience. So Dr. Hassani's just preparing his talk. So it will depend, I think, on the eye pressure. So if the angle is occludable, but the patient is only 40 years old, if they don't have symptomatic cataract, then why not do a laser iridotomy? Because what you're worried about is acute angle closure, or is there some other concern?
Biological changes is there. So 40 years.
For glaucoma?
Then we go for
Lens extraction. It depends. You can just use medical therapy. There's no reason to remove the lens early, because obviously you have the other risks of surgery. You're then committing them to surgery in the other eye as well, usually. So we wouldn't necessarily rush to perform lens extraction unless you can't control the intraocular pressure by other means. Yeah, so we're...
Okay. It hasn't started yet.
Well, there's been a bit of confusion as to what this session is, so...
I'm just
You're just here.
a presenter of the next.
So, Mr. Tayani, basically, we weren't told what to do for the session. Nobody gave any guidance, so we're digging out a talk for everyone.
Presentation.
No, presentations late because we were never told what to present. I don't know what the session is. Dr. Hassani has a talk that he's going to give. Dr. Hassani has a talk he's going to give. And then we're going to do a Q&A session. So if anyone has any questions.
This is a last minute adjustment. So
with the discussion introduction of the introduction. We could have discussion.
Yeah, if there are any questions anybody wants to ask about angle closure glaucoma, this is your time. No.
how do I do slideshow here?
So in Pakistan, is there a lot of angle closure? Is that what you see in most of your
Actually,
clinics, or is it open angle? What's the relative incidence?
Okay.
Open angle.
It represents about a third of the glaucoma blindness globally, with most cases being chronic in nature. Traditional methods, although somewhat effective, a lot of times do not address the root cause of angle closure and are associated with increased risk and complications. Newer surgical approaches are aimed at addressing these concerns by addressing the main cause, whether it be the lens angle or ciliary body. We're trying to restore the aqueous outflow, thereby improving outcome and safety. So who is at risk for angle closure? Basically, elderly, females more than males, family history is a risk, and certain ethnic backgrounds are at higher risk. The classic look, of the patient that comes in, very hyperopic patient, shallow anterior chamber, steep corneal curvature, thick lens, short axial length, and anterior position of the lens and or ciliary body. So the key to any good diagnosis is good assessment. And the gold standard is dark room compression gonioscopy, either with a Sussman or a Kepi lens. Anterior segment OCT is very useful as well to help identify structures, and also I use it to help with patient counseling. And one must not also forget the role of ultrasound biomicroscopy for the diagnosis of plateau iris. So let's review how to practically stage angle closure glaucoma. PAC is broken into 3 stages. You have primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. So what are these exactly? So primary angle closure suspect is when you have 180 degrees, 2 quadrants of closure, where you can't see the posterior pigmented trabecular meshwork. Primary angle closure itself is when you have the narrowing plus the IOP elevation or PES present. And then primary angle closure glaucoma is when you have all three, with optic nerve damage either showing up in your visual field or on clinical exam, or even OCT of the optic nerve. Just a terminology here, acute angle closure glaucoma is what we're all familiar with, but the newer term is acute angle closure crisis, where you have narrowing of the angles, increased IOP, corneal edema, nausea, vomiting, eye pain, and headache. The reason why we don't use the term glaucoma anymore is because sometimes if you catch these patients early enough, you can prevent optic nerve damage and visual field damage, so they don't truly have glaucoma, which is the crisis. So what are the main mechanisms of angle closure glaucoma? If you don't remember anything from this talk, this is what you need to remember. 3 major categories: pupil block, high lens rise, plateau iris. Keep it simple. So how do you distinguish between the 3? You look at the iris shape to get the clues. So on the left, you see a patient with pupil block. They have the classic bowing of the iris. You have the relative seal between the iris and lens, and you have aqueous trapped behind the iris. So you have that bowing of the iris. That's a classic pupil block we're all familiar with. You have on the right lens rise, where you have basically everything is rotated, is more anteriorly positioned. The whole lens complex is positioned. We've seen it where you look in, you're like, oh my God, the AC is so super shallow, both centrally and peripherally. And you look at the iris, it's almost like, very forward in its position. And the classic plateau iris configuration, where you have very shallow peripherally and deep centrally, and a very flat profile to the iris. And sometimes it has a finger-like projection to it. And the root cause of that is anterior rotation of the ciliary body. In reality, it's not that clean cut. Sometimes you get a very mixed picture, but the biggest culprit of the 3, most of the time, is lens rise. Okay, you have a big fat lens taking up space. So let's review practical management. General concept, I keep it simple with the fellows and residents. I said, listen, just address the cause. Treat the main cause. So you ask yourself, is there pupil block? If there is, PI. Lens rise, lens extraction. Plateau iris, combination of pilocarpine plus or minus argon laser iridoplasty plus or minus endocycloplasty, if you have access to it. It's obvious in real life, it's not often that easy to distinguish. It's a very mixed picture, so it ends up becoming a combination of treatments. So this chart nicely summarizes things in a perfect world. Pupillary block, medical treatment, LPI, lens extraction, filtration surgery. Plateau iris, medical treatment, LPI, argon laser iridoplasty, filtration surgery, and lens-induced is lens extraction. But we don't live in a perfect world. A lot of times the cause is very hard to distinguish. So when you see a patient coming in that has a look that they're in angle closure, you ask yourself some clinical questions. Is this acute or a chronic problem? Is the patient medically controlled or uncontrolled? So some anatomical questions you can look at, you can ask yourself just to get some clues into where to start. Is there an established PI present? If there's no PI present, then there's probably a pupil block component that needs to be addressed. Is there a cataract present? That means that if there is, then maybe a lensectomy or cataract extraction would be of benefit. Is there PAS present? If there is, that tells you there's a chronic component to this picture. So just general approach, max out the IOP lowering meds, hit it hard when they're, especially if they're in an acute attack, combination with pilocarpine, establish a patent PI to remove any component pupil block. Argon laser iridoplasty can be added if there's plateau iris component. Lensectomy for the lens rise component. So if the pressure is still high despite these measures, then we start thinking of angle-based surgeries, including goniosynochial lysis, ECPL for plateau iris, MIGS and MIS procedure to restore outflow, and then traditional surgery options as well, trabeculectomy and tube, but they do come with higher risk and complications in these sort of volatile scenarios. Just a quick word on primary angle closure suspects. These are patients that roll in with very narrow angles, but nothing else. They're asymptomatic. The traditional protocol when I was a resident, it was basically PI all these patients. But the ZAP trial in 2019 from China basically challenged this notion and said you don't have to PI everybody, so that may not be necessary, and only treat patients who are symptomatic, elevated IOP, very narrow angles, high, just high risk eyes, or the fellow eye had an attack. Whether or not you decide to treat or not to treat, leave that up to you as a clinician. But if you do decide to treat and do a PI, it's very important. Take-home message number 2 is to reassess the angle afterwards, re-gonio the angle afterwards. Because up to 60% of patients can still have occludable angles after PI, most likely due to either plateau iris or high lens rise or a combination of both. And usually those need to be addressed surgically. So if you do a PI and there's significant change in the IC depth, it significantly deepens, then you know that there probably was a pupil block component to this situation. So as you can see in the picture on the right, grade 1, narrowing, pre-PI, and then you do a PI, boom, it kind of deepens up, so the pupil block component has been addressed. But if you do a PI and there's no significant change in AC depth, then one has to consider plateau iris. I've talked about the anatomical features of that already. And high lens rise is another possibility. If you do a PI and it doesn't significantly deepen, sometimes it's a combination of the two. Lens rise is usually a significant component for most angle closure glaucoma cases. So removing the lens is a common theme in the management of angle closure. You're relieving the pupillary block, you're allowing the iris to rotate posteriorly, changing the vector forces, you're increasing the anterior chamber depth, and sometimes just by doing that, if there's a chronic component, you release some of the PAS, peripheral anterior synec, if it's mild. What I tell patients is kind of like, when I explain to them, I said, like, listen, you have a very fat lens, you have a small eye, we're taking that fat guy out of the room to create space, essentially what we're doing. Many studies have shown the effectiveness of lensectomy in angle closure. The most, I guess, well-known one is the EAGLE trial from China, where it's a large randomized controlled trial looking at patients with primary angle closure, no cataract, elevated IOP over 30, and they randomized to clear lens extraction versus PI. And it was shown that clear lens extraction had overall better health quality of life status, decrease in intraocular pressure, and was actually more cost-effective than a PI. So, phacoemulsification in small eyes, two major concepts. Number one, space creation. Number two, space maintenance. Okay, so these are eyes that are small, high hyperopes, even pseudo-X patients, they have loose zonules, so the lens is vaulted forward, nanophthalmic patients. And even eyes are just high, like, sometimes you're operating and they have just a really small looking eye. Remember these two concepts, space creation and space maintenance. So what is space creation? Space creation is, we're trying to keep the anterior chamber deep, so to make it easy to remove that lens, and also to protect the corneal endothelium. You can do this preoperatively with IV mannitol, just to dehydrate that vitreous. When you dehydrate vitreous, you're softening up things, the anterior chamber deepens up, makes it a bit easier to remove the cataract. It can be done intraoperatively with super viscous cohesive OVDs. In Canada, we use Helon 5 or Amvis Plus. I'm not sure what we use here, but basically a viscoelastic to keep the AC pressurized. One can also do a pars plana tap, where you're basically using MVR blade or trocar going posterior to allow fluid to decompress and create space in the anterior chamber. The other concept is space maintenance. So when you're doing cataract surgery in these patients, you want to keep the anterior chamber formed. You don't want the AC bouncing up and down, because every time that happens, fluid gets rerouted behind the lens bag complex, increasing the risk of intraoperative aqueous misdirection or malignant glaucoma. So the way to do this is to maintain smaller incisions, less AC turbulence. You can use an AC maintainer. What I tell residents and fellows is to keep the AC pressurized at all times with viscoelastic, OVD. Like usually when I find whenever intraoperative aqueous misdirection occurs, it usually happens during cortical removal or during IOL insertion. Like the lens has been removed, you're like, okay, I'm feeling really good about myself, and all of a sudden you see the AC start to shallow because fluid gets redirected back there. So in my fellowship, we were really harped. Every time you come out with irrigation aspiration, do not let the AC shallow. So you can see here, instead of coming out with the eye hand piece, make it a habit. Second hand instrument, viscoelastic, keep the AC formed, pressurize the AC, then come out. Okay, so you don't have the AC shallowing. When it shallows, then fluid can get redirected and cause intraoperative misdirection. So we're trying to prevent this problem. Malignant glaucoma, where you have AC shallowing, choroidal expansion, and basically the whole lens bag complex gets pushed forward. So if you run into this problem, the definitive therapy is to create a unicameral eye, where we're basically creating an open channel between the anterior chamber and posterior chamber. And this is done with the IZHV or IZH, iridozonular hyaloidotomy or hyaloidectomy or hyaluronic vitrectomy, whichever you want to call it. What you're trying to do is you're trying to create an open channel between the front and back, so you equalize the pressure to break that malignant glaucoma block. So there's different ways of doing it. You can do an anterior approach. Sometimes you have patients who especially sometimes after glaucoma filtration surgery, they were already narrow to begin with, and they show up with malignant glaucoma. So you can do an anterior approach in the office utilizing laser YAG approach. But sometimes it happens intraoperatively. You can't use a laser YAG, so you can use a vitrectomy cutter through a corneal limbal incision, or you can do a posterior approach with a vitrectomy cutter through the pars plana. So here's a video of my fellow basically doing cataract surgery. Just following the principles, IOL is in, everything looks good, but we start to realize he's running to aqueous misdirection. So we're doing a conjunctival cut down, MVR blade 3.5 millimeters posterior. Then we take a vitrectomy cutter. Now we're trying to inject this glass to try to create that space in the anterior chamber. We're creating space now with a vitrectomy cutter and breaking up the hyaloid face. And now we're doing the IHZV. We're creating that unicameral eye, create a huge PI basically to pressurize, to keep the pressure of the anterior chamber and posterior chamber equilibrated. And this is how we're treating basically intraoperative aqueous misdirection. And then the eye softens up quite significantly nice, and then we close up atovicral. Obviously, it's very important if you do something like this. It's not something we plan for, but something that happens intraoperatively. If you do something like this, you have to check the retina afterwards and get your retina colleagues to double check everything. So the extreme cases of small eyes is the nanophthalmic patient. These patients can be effectively treated with lensectomy, so you have to be aware of complications like uveal fusion syndrome or malignant glaucoma. But the concept of space creation and space maintenance is really important here. And I would probably avoid using any pars plana incision here because the anatomy is completely different. If you go 3.5 millimeters posterior, you're going to hit retina and cause retinal detachment. If you need to go back there, less than 2.5 millimeters. If you need to create that unicameral eye situation, less than 20 millimeters in axial length or malignant glaucoma in the fellow eye, do an anterior approach for the IHZV. And then patients who are really shallow eyes, small eyes, one can consider prophylactic sclerostomies. So here you can either use a steel crescent blade or a diamond blade in this case. You're basically cutting down through the choroid to expose the suprachoroidal space and just prevents uveal fusion, basically unroof the trabecular meshwork or gap procedures. And then also you can do stenting procedures. Many are out there, but the one that we use in Canada is iStent. You use MIBS procedures, which create new drainage, mini bleb, either Zen or Preserflow, and then phaco-trab or 2 for more advanced cases. But again, be aware of the higher side effect profile. In most cases, you can combine it. It's almost like when I tell residents that you look at the way to think of it is not just lowering the IOP. What's the problem? You try to tailor or customize your surgical solution to what the problem is. So a lot of times you end up combining many of these procedures together. So here's a case where the patient has a significant amount of goniosynovial lysis. So we're using the actual iStent inserter and just pulling down and just doing a goniosynovial lysis here to open up the drain. After we've opened up, we're basically using the iStent inject and artificially putting new artificial stents, and this is the iStent, to create a whole new artificial drainage site. And we do a few clock hours, do another stent here. And then finally, we're going to combine the other principle of using a goniotomy, where we're just going to open up the natural drain. You can do this with weed here. In this case, we just use the iStent inserter tip, but you can also use a hook dual blade. You can use a 27 gauge needle. You can use an MVR blade just to basically open it up. And when you open up, we're trying to purse open that lips. You can also use viscoelastic and just really squeeze in there and open up the lips to decrease resistance. So the concept here is what we're trying to do is restore outflow, change the anatomy of the outflow, and based on a targeted approach to what the problem is. So I sincerely hope that you found this talk practical and useful, providing a good overview, hopefully, in terms of medical management and take-home messages. Start with the basic, establish pain PI, relieving the pupillary block component, lensectomy for lens rise issues, and address the angle anatomy as needed, whether it's plateau or PAS, and you can restore outflow with other different myriad of techniques. Now, I'm aware that depending on what country you're from and where, the accessibility to resources is an issue, but it's good just to be aware of what techniques are out there and what's possible. Thank you.
Thank you very much for your very comprehensive talk.
3 weeks before, patient came with the phacomorphic glaucoma, lens-induced glaucoma.
Yes.
AC is shallow, corneal edematous, and hand movement is there, and pressure is more than 60. So how to proceed that one?
So cornea is edematous.
Yeah, edematous.
And so they're in acute angle closure. Is that correct?
Secondary
To the lens.
glaucoma.
So the first thing is, what we would do is get the pressure down medically. So, you'd give them acetazolamide, all the medical medications.
But the
and
medically,
mannitol.
pressure is down, yes, up to 30, not in less than 30.
And is the cornea
And
now clear?
by any bias, that pressure is not is come down.
Yeah.
Then how to proceed?
Yeah. So if the cornea is still cloudy,
Yeah.
yes.
Yeah.
So we had a similar case only a week or two ago, actually, in Cambridge. So we had, so there was a junior doctor's strike in England a couple of weeks ago. And so a patient came in through the main emergency department with severe headache. And she was initially mismanaged as migraine, maybe something going on, a bleed in the brain. And eventually they figured out she had acute angle closure. So by the time she came to us, it was a very severe attack. Pupil was widely dilated, refractory to anything. She couldn't have acetazolamide because she had an allergy. So she was admitted initially, given lots of other medications, and then given mannitol. So the pressure came down, but obviously couldn't do a PI on her. She couldn't have a laser PI. So initially I did a surgical PI. That was the first thing I did. But that wasn't actually successful because her pupil was so widely dilated that actually you couldn't see where the surgical PI was, and it didn't resolve. So her pressure started climbing up again. And then she couldn't have her cataract surgery. Cornea was bullous keratopathy. So then what I did was actually I did cyclodiode treatment for her. But interestingly, she had a huge pressure spike within half an hour after. Needed morphine for pain control, but the pressure actually came down. So I've left her, and the pressure has remained low. The cornea is settling. So her next procedure will be lens extraction. But if that is not successful, then I think she's heading for probably glaucoma filtration surgery. But her vision is already very compromised. So it will be a discussion with her as to what we do, what will be the benefit of glaucoma surgery. We're not going to recover her vision, I don't think, now.
I managed that case one just by surgical PI, and we keep on anti-glaucoma and anti-inflammatory.
Yeah.
After 2 weeks, we do the phaco is nicely.
Yeah, if you
Is
can
it
get the
okay?
cornea clear. For my patient, the cornea was cloudy, it was bullous keratopathy. Because it was she had that episode of acute angle closure for 3-4 days before she was actually diagnosed. So that was a problem.
The other thing you can also try, I've done it a few times, is sometimes surgical PI for sure. Like sometimes you're in the middle of the night and you can't, you just need to get it. You need to get it down, and you tried everything. IV mannitol, you've done everything. But sometimes we have like 15-degree blades. Put them at the slit lamp and just like a little like when you start off your cataract surgery, just do a little side port incision. Obviously, don't hit the lens, but just do a side port incision, and just by that, it lowers the pressure. And when you lower the pressure, the cornea clears up. A lot of times you can do that. When the cornea clears up, you can start to initiate a PI if you need to. But just that little trick alone, but bring it to the slit lamp. As long as sometimes if the AC is too shallow, then you can't do that. But if you feel like, hey, I have enough room to get a little side port incision, just like you would normally do when you start your cataract surgery, same thing. Just
So
do that.
paracentesis.
A paracentesis.
But you don't have much time with that. So if
Yeah.
you do a paracentesis,
It buys you time.
if it brings the pressure down, the cornea clears, you quickly do your PI,
Yeah.
your laser PI.
So
But-
like, so inflammatory condition, PI can.
Yeah, I agree with you. It's very difficult in those very inflamed eyes. Yeah.
I'm Dr. Ghulam Sanasi. When there is lens-induced glaucoma, white cataract, corneal edema, medically we are controlling with the acetazolamide orally and mannitol IV. Pressure comes down to 25, 30, and we think that if we leave it, the pressure spike will go up again. So in 1 or 2 cases, I did cataract surgery by phaco. While doing that, I took Vitis tab, 0.1, 1 or 2 units of insulin. I put Vitis. It made me very easy to remove the cataract and put the IOL in.
Yeah.
and that remained very good afterwards.
Yeah, that's actually a very good point. So we were talking briefly here about nanophthalmos, and so I've seen eyes where you operate on them, you do cataract surgery, you have a risk of aqueous misdirection, and also intractable effusions, uveal effusions. So my practice now for any eye that's nanophthalmic, and they're very rare for us to see, is that a week or two before I do prophylactic scleral windows. So a little bit more involved than what you saw in the video there. So what I tend to do is cover the patient with IV methylprednisolone, and then I do 2 windows, which you start by doing, it almost looks like you're doing a trabeculectomy. So you do a superficial flap, then you do a deeper one that cuts right down, and you excise that inner block. So it's a little bit like deep sclerectomy surgery. And then you loosely reposition the superficial one. So you've actually got it's a means of equalizing pressure so you don't get that uveal effusion. And then a couple of weeks later, I'll do the cataract surgery. So what works best for me is actually I work with a VR colleague. So I ask them to do a core vitrectomy first. That creates a lovely deep anterior chamber. Your surgery will be fantastic. And then actually I ask them to complete the vitrectomy and do a posterior capsulotomy as well so that then you've really got a belt and braces approach to preventing aqueous misdirection. So as I said, these cases are rare. I've seen about 2, truly nanophthalmic. When I say true nanophthalmic, the axial length of the last patient was 1.5 centimeters. It was 15 millimeter eye. So that comes with its own challenges. But the other thing to say about cataract surgery and angle closure eyes is that they have a much higher incidence of zonule weakness. So if the eye has had an episode of acute angle closure, you will get zonule dialysis. So be very, very careful. You may need a capsule tension ring in them, but handle the eye very carefully. And even if they've not had acute angle, an acute angle closure episode, statistically the zonules are weaker, so your risk of a problem can be higher. So yes.
When a patient comes with acute angle closure, the AC is already very shallow. You are doing paracentesis. Are you going to make it more shallow?
Yeah, you are going to make it more shallow, but not enough. You're not draining the AC, but you're just trying to get that pressure down so you can visualize to do a PI.
Is there any danger of going into malignant glaucoma?
I guess you can't get any worse than you are now. Like when you have angle closure, like there's only one direction to go up, improvement, right? So you're trying to get that pressure down. Otherwise, the other option is take them to do a surgical PI.
Or glycerol, topical glycerol is the other one.
Yeah, exactly. Other options too. But I'm assuming all medical options have been exhausted, right? Like for example, in Canada, we just can't go to it's not that accessible. So we have to come up with these solutions to try to.
This is the last resort.
Yes. I'm not saying do this the first time, but he was presenting a case where he's done everything medically, right?
But in those conditions that there is culture burn, if you make the short over the more shallow iris is the
it's very difficult to do a laser PI in a shallow.
Yeah.
But the other normally when you do a laser PI, you always do it superiorly, supertemporally, or but just do it wherever the AC is deeper. So if it has to be inferior, you do it inferior.
Yeah. Just get the hole.
Don't worry about I have to put it at the top.
Yeah.
Because just go wherever there's more space.
Yeah.
Don't because your priority is to
Just
get a
open it
patent
up,
iridotomy. It's not about worrying about anything else. So.
I'm sorry, I missed your talk, but I did up something with Khalid. You presented on the PI in the last session.
Okay. Yes. Okay.
Okay,
Yes.
so Ike has done a big paper on the temporal PIs, and
Yes.
then he says that if you do it on the 12 o'clock, it makes a convex lens, and then it causes diffraction and glare and dazzle.
Yes.
So I know that actually we've had a big session in Manchester, the whole hour. I think Asrani presented, and he said he used to always do nasal PIs, and Ike does temporal PIs, and they never had any glare and dazzle. I personally had 3 patients who really gave me a huge amount of grief. I don't do PIs, obviously juniors do, but they were all 12 o'clock. So
Yes.
my take home was that if you are to do a PI, try to find a crypt in the, preferably away from the 12 o'clock, maybe either in supranasal or infra or supratemporal or even temporal. And also the other thing is, if you look at the published literature, most of the papers are in the where they say that there is no glare and dazzle are from the cohort of patients in Asian countries where expectations are, I don't know, maybe they're not as high, but
Right.
have you anything to say?
I mean, I personally do, like, as you've alluded to, I do more super temporal or just temporal. That's what I do. But like, it's confusing when you look at literature. Everyone says something different, right? But when I was training, it was superior. Then temporal. I know Ike's temporal, and I kind of go anywhere in between. It's more towards temporal. That's what I interpret.
Just to add to that, I think the key is to look at the lid position and the tear meniscus. So if you go superior because they've got a slightly lower lid, it's fine. And similarly, if you go temporal, but what you don't want to do is have your iridotomy and the lid margin where the tear film's starting superimposed, because that's when you'll get the issues with dysphotopsia and, slight interference with vision. So look at the patient and not, you don't want to get them to stare, but just naturally look at them as to see what's their natural eyelid position.
But I've had patients where you do all the right things and they still have it.
Yeah.
So
there's no right.
that's why I always counsel patients. I said, they almost like expect it. And because I've had patients where you do all the right things, everything that she said, and they still get it. So I'm just like, I don't know,
So I have a very interesting 35-year-old who presented with headaches, and she had primary angle closure. So, they thought she had, the pressures wasn't that high, and then they did a superior PI. The patient was extremely unhappy, and then they found out the headaches were due to hypertension more than due to angle closure. Anyway, this is take home for me. Patients come with headache, you have to look at other things. So they completely miss the hypertension. Hypertension is a high blood pressure. And so, and then I had to get painted lenses and all sorts. And you know how then the misery prolongs.
Right.
Anyway, that's all I have to say. Thank you.
Questions about angle closure? Sorry. Mike?
I just want to share my experience that, anybody who already had angle closure glaucoma and we have done PI, but still it's not working. And now next thing next in line is that we have to take out the lens, right? So far off, before we proceed, there's always a chance that if we dilate the pupil, the pressure can go up, fine?
Yes.
And personally, it worked very well for me that if you do a PI before, surgical PI, and then you dilate, everything goes down. This is really helpful.
Yeah, I think there is a risk, but personally, I've never seen, or we've never measured the eye pressure, but I've certainly never seen an eye go into, acute angle closure just from dilation. And generally we don't put them at the end of the theatre list, they'll be earlier. But if the pressure goes up, you do a paracentesis, the pressure will come down.
The other thing you could do is that maybe if you're already doing it already, is just some IV mannitol right before.
Actually here, in Pakistan, we get most of the patients we used to come to were already referred cases. All the patients were 40, 50, 60 pressure like that. So you're struggling with it, maximum treatment and all that, and menthol, and you have to break the cycle once before you enter. But this is, I don't know, it worked for me.
Well, if it works.
I'm just asking.
It works.
You're the experts.
Yeah.
Everything just goes down.
Okay.
And you have
so you've broken the attack.
nice place you can just go and.
You might not need to do the cataract.
Thank you so much.
Yes, there's a.
Assalamu alaikum. I just want you to share your experience regarding short-term attacks, like for example in differential diagnosis of like patients of sleep apnea or like patients of Posner-Schlossman, like patients come with little acute attacks of painful eye, redness, tearing, and everything. But when you examine them in context of like glaucoma, they don't have closed glaucoma. Their gonio is fine. Like I just want you to share your experience how to deal with such patients. They don't have underlying inflammation or any like uveitis or something like that, but they do have symptoms occasionally, like few in like annually or something like that. So what's your opinion about these cases?
Yep.
Thank you.
I can start. Posner-Schlossman is largely a diagnosis of exclusion, but we do have patients who do have intermittent episodes. Now, if you know that is their diet, that's what's going on. They have these acute pressure rises. So if the first thing you want to make sure is that they don't have, they're not having intermittent attacks of angle closure. So, but once you exclude that and you know it's not that, then actually what we tend to do is give them some Diamox, some acetazolamide tablets, and we say, look, if it happens, you take 2 tablets of Diamox, and then you can come and see us. So, it might be in an evening or, when they can't get to the hospital. So we'll just give them usually oral medication and or topical, maybe some Cosopt that they have at home that they can start the treatment so that will address the acute pressure rise. But we have a couple of patients like that. But that's how we... Yeah, literally just short term. But we say to them, start the treatment, but come and see us within a day or so. And then what you can do is ask them to keep a diary or monitor. Now, if they're getting episodes more frequently, then you might want to consider a longer term therapy for them to stop those attacks. Don't know if you want to add anything to that.
Excuse me, there are 1-2 questions more. One is that there is small eye with the narrow angle glaucoma, and she has developed cataract as well. Would you like to do trabeculectomy first or cataract first? Number 1. Number 2, if you do phacotrab and again there is a high pressure, what will you do?
I usually address the lens first. First of all, I make sure there's a patent PI, like I do a PI before, just to make sure. And I take the lens out, and then whatever filtration surgery, if it's trabeculectomy, if that's your choice, or tube, or whatever other procedure you want to use. But the lens is the problem a lot of times, so that if you can, try to get that out first. That's
when you do the cataract surgery and see that there is a high CD ratio, and still there is a narrow angle, then what will you do?
So we kind of talked about here. So if you still have a narrow angle, then part of it you can also assess clinically. If there's PAS, like peripheral anterior synechia, then you're a chronic angle closure component. So you can deal with that either by peeling off the scar tissue, the goniosynechial lysis we talked about. If there's a plateau iris component, you can take the cataract out. And also, if you want to reshape that peripheral angle, either with iridoplasty or endocycloplasty. If you don't have access to that, then filtration surgery, would be useful as well. You can combine these procedures together, depending on what you have. But taking the cataract out is the most important thing.
I have a case that I have operated with combined extraction, combined
yes.
phacotrab.
Yes.
Again, she has high pressure. What to do now?
So you've done the phaco, you've done the trab. Are they in malignant glaucoma? Now, is the AC shallow still or no?
No.
AC is deep?
Not shallow. AC is better than before surgery.
Okay, so it's deeper.
Yeah.
And is the trab, is it failed? Is it scarred down? One could do, before jumping into more surgical procedures, just trying to resurrect the bleb, make sure that the trab is working properly.
I think there is a bleb, but that is a diffuse bleb.
Yeah. The other possibility, multiple options, you could do another trab if you want it, or a tube, or CPC treatment, like micropulse type of treatment. If you like in Canada, we do other like bleb type, angle type based procedures. But yeah, before you jump into all the surgery, make sure that it's just not just your trab is not functioning properly.
I don't think some misdirection of the aqueous might be there. Should we go for posterior capsulotomy and anterior vitrectomy in that case?
Oh, okay. So you're asking if there's, well, usually if there's, you're talking about a malignant glaucoma situation.
I suspect in that case.
Yeah, usually with malignant glaucoma, you tend to have a shallow anterior chamber with high IOP.
But
Unless you have
in this case, there is no shallow AC.
Yeah, I mean, I wouldn't malignant. I mean, I wouldn't jump right to the posterior segment in this situation because usually with malignant glaucoma, it's a classic appearance. You can have enough post filtration, shallow anterior chamber, high IOP, and everything sort of vaulted forward. Then yes, I would consider a pars plana tap and IZHV. But if it's deep, then check the trab, make sure it's working properly. And sometimes the trabs fail, and you might need another procedure like a tube or something. That's fine. Yeah.
First off, the incidence of phaco trabs, failure of trabs in combined phaco is quite high. Failure is about 50%.
Right.
So if first off, if your lens size is not too big and AC to lens ratio is not very high, then you potentially could have done a trab and then waited for 12 months or at least 9 months and done a cataract surgery if you had to do it. Otherwise, you leave it for as long as you could leave it. Anyway, in your situation, I wouldn't take too much time, but in your situation, when did you do the phaco trab?
It's about 3 months back.
Okay, so you got 3 months. So did it ever work? That's the question. Did that trab work? Okay.
Very good.
Okay.
The first one, post-op, it was very good, but it's now getting.
Can I ask you what percentage of mito you used?
The axial length of that eye was 20 millimeter.
20?
Yeah, 20.
Okay. So so the obviously you're lucky that you didn't have choroidals because you could have had a hypotony in it's a very short axial length patient. Anyway, so now the options you have are, if you did have a functioning trab at the outset, you potentially could open the patient up because it's 3 months, and then you can revise your trab. I would definitely put some releasable sutures, and I would use some maybe even depending on concentration of mitomycin you used, and depending on the age of the patient and the ocular surface, how injected it is. I may use 0.4% or 0.2% mito, and then I would revise my trab, because you have then that's it. You got to just give him one second chance, and then put him on hourly or Predford and really nurture it, really nurture it, because phaco trabs, as I said, have a very high rate of failure. And then if that doesn't work, sadly, then I think my next option would have been to put a tube in that patient, and I would sit on the patient and I try to give 6 months, or maybe for as long as I can buy some time.
Yeah.
Because I know that mixed procedure unfortunately do not exist here. So.
Yeah. So I mean, we're on the same wavelength. I mean, I don't think your scenario was more of a malignant glaucoma. I mean, what you're describing.
I think you have to do a UBM and look at the, you have to look at the lens position and see, because unfortunately with the malignant glaucoma, you can have in-betweeners and they may not be a full-fledged malignant glaucoma. But you're saying the AC is fairly deep, you said. So in that case, I think you've just got to try to revive your trab. 3 months is not that long a time. You may be able to salvage it, but you'll have to go the extra mile now, because have you needled the patient yet?
Thank you very much. I think we need to move on because the next session's starting. We're over time now.
Thank you very much.
Before we go, can I just ask everyone, there are a very good series of papers that are published by Clement Pham from Hong Kong, and they address your very question, whether you should do cataract first or trabeculectomy first in an eye with angle closure. And these studies clearly show that if the glaucoma is uncontrolled, simple removal of the lens will result in pressure control in 85% of eyes without the need for subsequent trabeculectomy. So just to reinforce, lens extraction should be your first procedure. But have a read of those papers.
Thank you very much.
That's the end of the session, guys. So.
Thank you.
We'll let you